we rarely see a child who dies of Hodgkin's disease. And if it is, it's usually a very older, towards the end of that age range. On the other hand, you see the acute non-lymphoblastic leukemia, which in the 70s was around 20%. I think our first survival of a child with AML was diagnosed in 1971 or 72. That was the first patient, she's still alive, by the way, who survived AML. That has improved significantly. We're up around 55%, 55%, but certainly not at the levels of other cancers. Another area where we've made not nearly as much progress is the area of brain tumors, and that is this curve right here. You can see it's slowly gone up a bit. It's a little deceptive because about half of brain tumors are low-grade tumors that tend to be treated with surgery alone or radiation and often kind of peter around for a long time or are cured. But if you look at the subset of those brain tumors that are malignant brain tumors, highly malignant brain tumors, there has been very little improvement in survival on those. A little bit, but not much. So that's the other real big challenge that we have. Just to show you the picture in acute lymphoblastic leukemia, many of you have seen slides like this before. Again, if I were to draw the slide from 1950, it would have gone down like this. And one of these days I need to put that on the slide. But you can see we've made stepwise progressions in the improvement in survival in ALL. It's not been a magic bullet that's come along and suddenly changed things. It's really been stepwise improvements, but there's one big improvement here. And that was because of the understanding from research that the spinal fluid, the central nervous system, was a sanctuary, and that the therapy we were using up to that point, systemic chemotherapy, did not get access to the spinal fluid, and that we had to do something specifically to address that sanctuary, which we did initially with radiation and intrathecal therapy, and now we're really eliminated radiation for all but about 15 or 20% of these patients and use just intrathecal therapy, and that was the reason for this huge jump in outcomes. And we've made successive improvements as we've intensified therapy, added a few new drugs, developed new ways of giving the drugs, and that's resulted in increasing strategy improvement. And you can see what's happened, and I'll show you a little bit, I'll show you a little bit better curve for the recent, there we are. Hang on, one more. There we are. This is sort of the most recent data I could put out, but I think there's probably more coming out sooner. We're seeing survivals now running in the 87% range is the current 5-year survival for ALL, if you can believe that. 87% children with ALL are alive at 5 years, the vast majority of them off therapy for 2 or 3 years by that time. So it's really been a dramatic improvement, and we're expecting that to continue to improve as well. It's getting harder to show that we're improving because you're comparing small changes in survival. You need a lot of patients to show the improvements. Now, just very quickly, how have we gotten there? Well, just looking back again on the history of our care, prior to 1920, surgery only. In 1940s, we started using radiation therapy. With those two treatments, you could deal with local disease and disease that was in the immediate tumor bed, but not surprisingly, the survivals were around 10% overall for things like leukemia. They were 0 because of the systemic nature of the disease I mentioned. Even though you couldn't see cancer in other sites, it popped up over time, despite the fact you controlled the local cancer. Systemic chemotherapy came along in the early 1950s, late 1940, actually 49, I think is when Sidney Farber began publishing stuff about aminopterin. Single agents followed by combinations of agents, improvements in survival gradually as we realized that we could give combinations, that we could give maintenance therapy, that we could give therapy to patients who looked like they were free of cancer after their initial surgery but really weren't, and that resulted in better survival, so-called adjuvant therapy, and improvements in radiation therapy techniques. In the 1970s, we began to understand the sanctuaries, things like the spinal fluid in leukemia, the testes in leukemia, the eye as a sanctuary in leukemia, and there's several others, and bone marrow transplantation first began to be developed. Now, even at this early point, We never would have been able to make those improvements if we didn't have concomitant improvements in supportive care. Chemotherapy would not be possible to give if we couldn't give platelets to deal with thrombocytopenia. I remember when I started out in the late 60s, we had at least as many children who died of uncontrollable hemorrhage, usually in the bowel or in the head, as they did die of infection. We didn't have a way, we had whole blood, we give them whole blood to give them platelets. You couldn't get many platelets in, there's a limit of how much whole blood units you could give, and patients literally bled out because of thrombocytopenia. Now, with the development of platelet transfusions, that has changed dramatically. Not completely gotten rid of it, but it's changed dramatically. In many institutions, half the children with ALL developed pneumocystis carinii pneumonia during their therapy, and most of them died. Now we can prevent that from happening in all but a very few patients using Bactrim or other prophylactic measures. We had children dying of graft-versus-host disease because they would get a blood transfusion and the lymphocytes in the blood product would graft them because their immune system was compromised by their cancer and their therapy. They would graft the donor lymphocytes from the blood transfusions and they would die of GVHD. And we learned that you have to irradiate all blood products to these immune-suppressed patients to kill the lymphocytes, so you didn't have that problem. That improved outcome. These just an example of some of the important supportive care measures that people forget about that needed to happen to make this kind of therapy even possible. All right, so in the 1980s, as survivals began to improve, we started to look at, well, how can you tell that subgroups of patients with, let's say, ALL are going to respond to a given therapy the same way. We found out that, in fact, there were various prognostic factors, simple things like age and white count, now much more complicated ones like molecular patterns, that really define subsets of different cancers that would tell you how they would respond to a given therapy in general. And you could therefore start to think about how to develop therapy for those subsets. We also, and there was a lot of leadership here from groups in Germany and Europe about this, we also began to realize that the opportunity for the most kill of cancer cells was during the first 2 or 3 months of treatment. This was the period of time when these cells would be most sensitive, most likely to be rapidly killed, and therefore intensive high-dose therapy up front became a paradigm of treatment, particularly for leukemia, but for some other cancers that was introduced into the therapy regimens. With the prognostic factors that we developed, we were then in the 1990s into the era of risk-adjusted therapy. That means that I have a patient with ALL, I look at their prognostic factors, I'm able to categorize them into patients who are going to respond very well to standard therapy, a group that may respond intermediately, and then a group that responds terribly. And we could then design treatment protocols or studies specific for those subsets. Maybe reduce the intensity for the patients who do very well with standard therapy, but obviously come up with very novel new therapy for the patients who don't do well. So we didn't treat them as a group anymore. We treated them as subsets. And that's true of many different kinds of cancers now as we've developed these prognostic factors and risk groups and then develop therapy for each subset. Here we are in the 2000s, and as you know, with the tremendous new technology for molecular analysis, we are developing targeted anti-cancer therapies, and we're starting to talk about, as you've heard recently, personalized cancer medicine, which really means looking at the molecular phenotype of a patient's cancer and choosing therapy based on that phenotype. We're already doing that, by the way. If you think that that's sort of like something science fiction coming, we're doing it already. And the best example are, a good example are patients with leukemia who have the Philadelphia chromosome. It's not just CML, which most of you are probably familiar with, chronic myelogenous leukemia. It turns out that about 10% of ALLs have the PH positive, have the PH chromosome, and even some AMLs have it. And not surprisingly, these patients respond to the use of a targeted agent to the Philadelphia chromosome product, the BCR-ABL product tyrosine kinase, and that agent is Gleevec. You all have heard about it, but that is now not just been introduced to CML, it's been introduced to ALL. And where pH-positive disease in ALL used to be a bad factor, if you add in the Gleevec to the other part of the therapy, you actually bring their survivals pretty much up to where many of the other patients are. So that's a great example of, you know the phenotype, you know the molecular phenotype, you can add a specific targeted agent to that patient.